thanks again. Hopefully a little bit shift. My talk is a little bit more technical. So hopefully you'll enjoy this. So pedal access for primary intervention. The term TAMMY or assisted TAMMY. TAMMY stands for tibio-pedal arterial minimally invasive retrograde revascularization. And really, what is the difference between the term TAMMY and assisted TAMMY? TAMMY is a procedure performed from tibio-pedal access only. So you obtain access, place a sheath, deliver therapy, do any kind of form of therapy just via pedal access. The term assisted TAMMY is basically, if you remember my talk about chronic total occlusions and requiring dual access, antegrade and retrograde access, well, we thought that we want to still deliver therapy via pedal access, but we require an additional access to help us cross the CTO, hence the term of assisted TAMMY. So the TAMMY technique, pedal access only, diagnostic angiography via pedal access, the use of extravascular ultrasound and intravascular ultrasound. You can use devices, any atherectomy device, or for the most part, majority of atherectomy devices. You can perform balloon angioplasty, you can perform drug-coated balloon angioplasty, and you can actually place specialty balloons and self-expanding stents. So these images are about 8 years old. One of our research nurses, we said we wanna visually try to explain to physicians where do these vessels run when they're trying to obtain access. So as you can see here, no groin access whatsoever for these patients, obtaining access either for the DP, anterior tibial artery, posterior tibial artery. And what you see in the middle is even trying to cross from one of the tibial vessels to the contralateral tibial vessel, so from the AT to the PTO and vice versa, in some cases, in some instances. Or even go as far as treating the SFA and the popliteal. And why this concept of TAMMY? Because of the nature of our practice, we deal with a lot of CLI patients. And CLI patients, they have a lot of comorbidities. They're sick people, they're sick patients. And the reality is you want to be able to help for a lot of them. And we've all been faced with that situation. So if you notice that as a cardiologist, we always think about growing complications, right? So there's nothing worse than doing a beautiful case, and at the end of the case, you have a massive hematoma, and the patient needs transfusion and longer stay in the hospital, and all the benefit that you achieve has been outweighed by these complications. So anything we can do to avoid complications with patients that had prior surgeries or morbid obesities, anything we can do, we pursue. Now, the term assisted TAMMY is we obtain a 2.9 French or a 2 French or 3 French access within the superficial femoral artery of a common femoral artery. And now think about it, 6 French sheath versus 3 French sheath, right? So the risk profile decreased tremendously with those patients. And if I'm able to use an 018 catheter to help me tackle that CTO, still deliver therapy via pedal access, then the risk of complication is extremely lower for those patients. I showed this slide before. It's not let's see what happens when it comes to CTOs. We try to follow a process with the CTOP classification. Believe it or not, the biggest predictor for patients requiring another access is 2 things: calcifications. Severe calcifications are 8 times more likely to require an additional access, and the longer lesions. Every 10 centimeters, you 1.7 times with odds ratio, increased odds ratio of obtaining another access. So keep that in mind. All right, so let me show you a TAMMY technique. This is a patient that has Rutherford class 6, non-healing TMA site with a heel ulcer. Multiple risk factors, as you can see. Unable to lay flat because ventilatory issues, and had a recent excuse me, left lower extremity intervention on the POP, TPT, PT, and perineal. The TMA is healing has slowed, and this is the phone call that you get from the wound care specialist or the podiatrist, and we wanted to treat the anterior tibial artery. So this is real-time pedal access, long access view, just to show. Obviously, we like usually short access, but I just want to show here the anterior wall and the posterior wall of the vessel, and the wire being advanced through. This is an occluded vessel. There is no good flow in this vessel, and the wire is being advanced. And if you look all the way to the right panel, this is our access within the posterior tibial artery. You see a hint of the flow beyond it. But then you place a sheath and you cross all the way to the common femoral artery. You do your diagnostic angiography, and you can see that the patient has a popliteal lesion, has an occluded anterior tibial artery. There's maybe a hint of a dorsalis pedis artery, but no adequate flow within the plantar circulation. We use IVUS, so this is just to show you that you can use IVUS for these cases. Excuse me. And we chose laser atherectomy for this case. We treated the popliteal posterior tibial artery, and now we brought our attention to the anterior tibial artery. This is a patient that we really wanted to avoid common femoral artery access. It's still feasible, but we want to avoid it. So we crossed with the catheter from the posterior tibial artery to the anterior tibial artery, and we obtained access to the dorsalis pedis artery. And now we have a floss system from the anterior tibial artery to the posterior tibial artery. And we're able to perform also IVUS treatment, laser atherectomy, and balloon angioplasty. And the goal behind showing you this case is just to get you thinking about the possibilities. It's not about that, everything that can be done this way. Obviously, there are limitations. But I just want to have you think about, well, some of these patients have options if you can achieve this treatment. And we finally chose to address the posterior tibial artery access site because there is a hibernating lumen beyond our access site within the dorsalis pedis artery, and this was the final angiographic result for this patient. So why assisted TAMMY? Same limitations like the TAMMY technique. Hemostasis may be achieved via pedal access. So we actually, once you cross the CTO, you can actually balloon the access site in the common femoral artery and the SFA and not be concerned about it. And it's an EVIS guided closure. And just a reminder, like why do you really want to avoid SFA and common femoral artery access? This is why, and a lot of us had patients that we had the situation. This is an unfortunate gentleman, 47 years old. Had wounds in the past, developed rest pain again, multiple risk factors, and in ultrasound in our office showed evidence of iliac disease, occluded left superficial femoral artery, and single vessel runoff via the posterior tibial artery. And the CT angio was performed demonstrating included left common iliac artery. Patient underwent left common iliac artery vascularization and was staged for the left SFA intervention. So I wanna emphasize, if you notice throughout the talks for the multiple speakers very eloquently pointed out that you really, for CLI patients, you really need guided, directed therapy toward the foot. And the concept of let's treat and see what happens, unless you really have a good relationship with the patient or these are your patients and you follow them, tend to give less optimal results for those patients in my experience and based on the data. So this angiogram or this ultrasound image that you can see, the left of the screen is the common femoral artery and the right of the screen is the SFA. I want to point your attention to something, and I think we brought it in one of the live cases today, that the underperfused vessels. This is an occluded SFA. You can see it's a hypoechogenic vessel. You don't see a lot of calcium in it. And what we decided to do is basically we punctured the occluded superficial femoral artery. You can't do that fluoroscopically. There's no flow through it. So we actually was able, like as you can see, this is the bright line is the wire being advanced into the occluded superficial femoral artery under ultrasound guidance. And we access the posterior tibial artery. And what you see is what we call the tunneling technique. And now we have a wire that's through and through between the superficial femoral artery all the way to the posterior tibial artery. We did an angiogram, and the angiogram now shows that you have a perineal artery that was not shown on the CTA. And that's another thing. CTAs tend to underestimate the flow within the infrapopliteal vessels. So if you have a CLI patients, you really don't want to depend on a CTA for those patients. And ultimately, we crossed, treated the vessel, and this is EVIS guided measuring of a balloon apposition against the wall, the arterial wall of the vessel of the patient, and delivered the balloon angioplasty, did an angiogram, and this was the final result for the patient. Now, this is this is an ultrasound guided closure of the posterior tibial artery, which was the primary access point, and you can see the flow immediately after we pulled the sheath, a few minutes after. And then finally, when the patient is in the recovery area, you see that there is excellent blood flow beyond our access point for this patient. I showed this data for the TAMMY technique, and because what Dr. Marian said, I'm not gonna elaborate on it because I have 100 patients. But but in fairness, this is relatively a new technique, and who's gonna be interested in funding thousands of those patients? So maybe I can call Dr. Marian later on and see if she can offer me some pointers. Yeah. But if you compare it actually to the traditional 840 procedures that are done via femoral access versus dual access, antegrade, retrograde, and the TAMMY technique, that's the biggest concern, right? Everybody says, well, you're gonna burn bridges, you're gonna create thrombosis, you're gonna create compartment syndrome. Rightfully so, we should be concerned about them. But if you look at the small trials, not only this one, but if you look at the small trials, it really did not manifest itself as a complication when it comes to ultrasound guided pedal access. It's just there isn't that many, which is a good thing because it's a good option for some of those patients. All right, I showed this before. Again, I want to thank the organizers, PK, for inviting me. You guys have been great hosts, and thank you very much.
Thank you. Well, that was a great lecture. Any questions for Dr. Saab first, and then we can ask. Go ahead.
So my question is, with primary pedal picking up speed in a lot of places, especially OBLs, what is the long-term outcome when you're accessing these end arteries? Because they often compare it to the radial. When in upper extremity, you rarely see significant disease. So when you're accessing these end arteries, patients with so many comorbidities, are you risking that you're, jeopardizing a vessel where you might be accelerating the process towards CLI?
Yeah, that's a great question, and the answer lays in a couple of issues. Number one, a lot of the times we access occluded tibial vessels under ultrasound. So in that sense, you're really not burning any bridges because your access site itself is not there to begin with. So that's one issue. The other issue is it really varies depending on the center. So for example, in our center, we have an interventional ultrasonographer. So we scan these, we perform ultrasound to perform closure on those patients. So we track our outcomes immediately, but that's not common, or that's not performed at each and every center. Each person has their own practice. Anecdotally, I will tell you that there's a difference between access to cross the CTO with the 2.9 French sheets. In the small case series, again, did not show any issues with acute closure for those cases versus delivering therapy via pedal access. Anecdotally, we found that if a vessel is smaller than 2.5 millimeters for delivering therapy, then you might have an issue for those patients.
Question?
If you have a normal common femoral artery, like superficial is fine, would you recommend the TAMMY technique? Because I'm thinking, why making complicated something that is simple, that you can do simply? So could you tell us, like, the way to get access with TAMMY technique? When would you 100% utilize it?
Yeah, that's a great question, and again, as a cardiologist, I'm gonna borrow the debate between common femoral artery access and radial access for coronary interventions, right? And this is kind of where we at when it comes to pedal access versus common femoral artery access. I'm the first one to say, obviously, we need more data. It, So I will tell you that our practice pattern is a little bit different because of our high percentage of CLI patients within our practice. Almost 80-90% of our patients are such. So we tend to use pedal access more frequently, but we do have these safety steps in line with having a dedicated interventional ultrasonographer in each and every procedure. And I noticed today, like for the live cases, all the cases were up and over. If you look at Europe for CLI cases or patients or physicians that intervene on tibial vessels and plantar circulation, the majority of access points are actually integrate common femoral artery access. So the practice patterns are different. But you said something very important. You made something between SFA and pedal access, taking something very simple and making it complicated. I like how you said that because you're absolutely right. It really depends on the physician and the center experience, right? So if this is a center that's comfortable with ultrasound guided access, pedal access, then great. If it's something that you do once every 3 months, then you're not going to have good outcomes, right? So like everything else with what we do, you need expertise within the center. So yeah.
Any cocktail or things that you use, Fadi, for just some practical tips and tricks?
Yeah, so we've I don't want to call it our own concoction, but when we published the TAMMY series, the earlier one in 2000, I believe 2016, it's called the TAMMY solution. It's basically 500 cc's of heparinized saline and 5 milligrams of verapamil and 3,000 micrograms of nitroglycerin. Please don't call me on that. You can look it up. I'm just working from memory. And you need to infuse it at a rate of 10 cc's per minute.
So it's
And
infused
we
through the
kind-
sheet.
Yeah, and we kind of made it. We counted how often we give nitro, so we infuse it continuously through a sheet.
I got it.
Now I'm the first one to tell you, was that compared to not giving it
No,
all the
I
time?
understand. Yeah.
We didn't randomize it. So
Right. And how far up in the can you treat aortic disease from this, or you're not doing that?
that is the exception, not the rule. I've done it before in certain like really difficult situations, but I would say it's an exception, not the rule.